عليكم. I will start two lectures about the surgical disease of the anal canal, and after that, two lectures about surgery of the rectum. First, we look for this diagram. This picture in female, this is the uterus anteriorly, and behind the uterus, there is uterus and vagina. Below of it is the rectum, and this is ring by puborectalis muscle. Also in this picture, clear external anal sphincter and internal anal sphincter. This is very important to understand the surgical disease related to the anal canal and the rectum. Also, this is a relevant anatomy of the anus and the anal canal. There is puborectalis muscle, external anal sphincter. There is three parts of external anal sphincter, and there is internal anal sphincter, which is important. It is condensation, continuity, lower continuity of the circular muscles of the bowel, whether small bowel and large bowel. And there is intersphincteric space between external and internal sphincter. This is important in pathologies related to the anal canal and also to the rectum, like pilonidal sinus, like abscess, fistula and ano, different type, low type, high type. And this is the lining membrane of the anal canal and the lower rectal mucosa. The anal mucosa, which is reddish in color, and that is of lower part. Anal canal, it is 4 centimeter, 2 centimeter above the dentate line, and 2 centimeter below the dentate line. Reddish color, this is above the dentate line, and this is whitish, which is skin below the dentate line. This is also important, especially in hemorrhoid development. Regarding the anal canal, starting with the disease of the anus and anal canal, you have to understand the anatomy, blood supply, venous drainage, and lymphatic drainage, the signs and symptoms of anal disease, and how to examine the anal canal, type of investigations related to the anal canal and benign condition, and to know signs and symptoms of pilonidal sinus, hemorrhoid, fistula in ano, anorectal abscesses, fissure in ano, this disease related to the anus and anal canal. Surgical anatomy, according to the picture at the beginning of this lecture, the anal canal commences at the level where the rectum passes through the pelvic diaphragm and ends at the anal verge. Internal sphincter, it is thickened continuation of circular muscle of the rectum. It is involuntary white in color, about 2.5 centimeter and 2 to 5 millimeter thickness. Spasm of this muscle causes anal fissure. External sphincters, it is pinkish in color. Voluntary somatic innervation can be divided into deep external anal sphincter, superficial and subcutaneous portion. Intersphincteric plane or intersphincteric place, it is a potential space lie between internal and external sphincteric muscle. It contains 8 to 12 apocrine glands, which can cause infection, and it's also a route of spread of pus. It is also can be opened by the surgeon to provide an access for operation. The puborectalis muscle, it's play a key role in maintaining the angle between the anal canal and the rectum, and hence is essential for preservation of continence. لذلك احنا continence of fecal material depend mostly on puborectalis muscle and on internal and external sphincters. Anorectal ring, it is the junction between anal canal and the rectum, is formed by junction of puborectalis muscle, deep external anal sphincter, and conjoined longitudinal muscle. And the highest part of the internal sphincter, the ring can be felt digitally, and division of this ring will cause permanent incontinence of feces. The dentate line, it is important landmark to present of a fusion of a proctoderm and post-allantoin gut. It separates the mucosa lining at the line is a transitional between epithelium and squamous epithelium. Transitional between cuboid epithelium and columnar cuboidal and between squamous epithelium, because anal canal 4 centimeter divided 2 centimeter above, there is columnar epithelium, columnar to cuboidal epithelium, while 1 centimeter, 2 centimeter below dentate line, there is squamous epithelium. Above cuboid epithelium, autonomic nerve, insensitive, and portal venous system, while below dentate line, from squamous epithelium, from spinal nerve, sensitive, and from systemic venous circulation, from systemic circulation. إذا الدنتيت لاين راح يقسم لنا الانال canal part with venous drainage to portal circulation, while that below dentate line, the drainage to systemic circulation, also the innervation. The blood supply of the anus and anal canal supplied by branches from superior, middle, and inferior hemorrhoidal artery. Superior hemorrhoidal artery give left terminal branch and right branch divided to anterior and posterior. إذن السوبيريور hemorrhoidal ينقسم left و right، والرايت كذلك ينقسم إلى anterior and posterior branches, arteries, anastomose with each other, producing intramural plexus. Venous drainage. Superior hemorrhoidal vein drain the upper half of the canal to inferior mesenteric vein, then portal vein, while inferior half of the canal drained by inferior hemorrhoidal vein to the external iliac vein, which is systemic venous circulation, each side on the anal canal. Okay, natal venous drainage. Superior hemorrhoidal vein drain the upper half of the canal above to the inferior mesenteric vein. وتعرفون الانفيريور mesenteric vein يروح للسبلينيك vein، اللي السبلينيك vein وهي superior mesenteric vein بيكونون لنا البورتال vein behind the pancreas. While the lower half, inferior part of the canal drain via inferior hemorrhoidal vein to external iliac vein. Lymphatic drainage, upper half drain to upward to the posterior rectal lymphatic, then the para-aortic lymph node, while lower half to superficial inguinal lymph node, then to deep inguinal lymph node. This is important, especially in dissemination of carcinoma of the anal canal. That's to say, tumors above the dentate line will drain upward to the post-rectal lymphatics, lymph nodes, and to the para-aortic lymph nodes, while the lower half drain to superficial, then to deep inguinal lymph nodes. Examination of the anus positions, lateral or lithotomy position. And examination of the anus and anal canal include inspection, digital examination, and proctoscopy. By inspection, at the end of inspection, ask the patient to strain downward. By inspection, we see if there is abscess, opening, external orifice of fistula, fissure, skin tag, external hemorrhoid. All these can be seen. Also, pilonidal sinus in the posterior of the coccyx. All these can be seen by inspection. Digital digital anal examination with index finger طبعا should be lubricant with xylocaine, intraluminal for intramural wall of the anal canal and extramural. There is disease in the lumen like fecal impaction or foreign body, then intramural or intramural wall of the anal canal like carcinoma, and extramural related to disease like huge abscess outside the anal canal and masses that compress the anal canal. At end, also ask the patient to strain. Why we ask the patient to strain? Because the pathologies would descend by pelvic floor downward. At the end, by manual examination is important to check the pelvic organ. By manual examination, especially in the female. Then feel prostate in the cervix, in the male, sorry. Then you have to feel the prostate in the male, the cervix in the female, uterus, pouch of the glus in the female. You have to feel by rectal examination, examining the finger through the anal canal. You check the prostate in the male. In female, you have to check the cervix, uterus, pouch of the glus in female. Discharge from the anal canal. Also, we look for the gloves and look, is there fecal material? If there is a bloody mucus material, this is important because there is a lot of disease like ulcerative colitis, like Crohn's disease. If there is bleeding hemorrhoid, all these, there is certain fecal material with certain color on the examined finger. Proctoscopy, by which can visualize the lower 1/3 of the rectum by proctoscopy, anal canal and anorectal junction. Use as a treatment of hemorrhoid by injection or banding and can be used for biopsy. إذن البروكتوسكوبي اللي هو about 12 centimeter, 12 to 15 centimeter راح طبعا ويا تروكر راح نشوف به lower part of the rectum, lower third of the rectum and anal canal above the dentate line and below dentate line, origin of the hemorrhoid, and also if there is another pathology at anorectal junction. Sigmoidoscopy can be examined the rectum and the lower sigmoid, and there is two types, whether we use flexible sigmoidoscopy or rigid sigmoidoscopy, or rigid sigmoidoscopy can be therapeutic and diagnostic. Congenital abnormalities of the anus and the anal canal. Perforated anus, 1 in 4,500 incidents, divided to high or low types. Perforated anus abnormalities divided into high or low type according to the bowel termination, whether above or below the pelvic floor. Low type, easy to diagnose and easy to treat, and prognosis is good. High type may be associated with fistula to the urinary tract or deficit of pelvic floor. Then عندنا two types of abnormalities, congenital abnormalities of the anal canal. It is either low type اللي هي easy to diagnose and treat, or high type اللي هي عادة associated with fistula to the urinary tract and sometimes deficit in the pelvic floor. Example of low type abnormalities. First, covered anus covered with bar of skin. Second, ectopic anus may open in the perineum or vagina or the vulva. Third, stenosed anus, minute opening. And fourth, membranous stenosis, anus covered with thin membrane. All these low abnormalities, and all of these can be treated easily, while high type include anorectal agenesis, rectal atresia, and cloaca. Cloaca occur in female. Here, the bowel, urinary bladder, and genital tract all open into common wide cavity named as cloaca. This is more common in female. Here, the bowel, urinary bladder, and genital tract open to one orifice. And the management of the abnormalities, congenital abnormalities, after 6 hours from birth, sufficient air may collect in large bowel, and a metal button, قطعة معدنية, coin, insert to the blind anal canal. Then the infant is held upside down. يعني الطفل نخلي راسه لجوه والمؤخرة مالته اللي فوق، ونخلي كوين قطعة معدنية for 3 to 4 minutes، يعني حتى ننطي وقت للغاز to ascend, and radiographed in inverted position. Then measure the distance between gas shadow. It is more than 2.5 centimeter. It means the abnormality is high. يعني انه البيبي العفو النيوبورن نمسكه يعني بالعكس head down، ونخلي قطعه معدنيه coin above يعني the level of anus and anal canal, and take X-ray. If the distance more than 2.5 between the coin and the gas, 2.5 centimeter, it is high abnormality. The treatment of congenital abnormalities, low type, easily and simple. High type is so difficult. Most of patients end with colostomy after division of the urinary fistula. For high types, you must prepare the baby for operation. There are many possibilities as يعني for treatment of high abnormality. Either laparotomy, exploratory laparotomy, division of fistula and colostomy, or laparotomy, division of fistula and pull-through operation in one stage, or colostomy only as in the cloaca. Another congenital abnormalities, sarcococcygeal teratoma. It is rare, but it is the most common large tumor seen during the first 3 months of life. Females are more often affected than males. Even most common large tumor during the first 3 months as a congenital abnormality in a newborn baby. Female are more often affected than males, than the tumor which arise between the sacrum and the rectum is firmly attached to the sacrum. The tumor which arise between the sacrum and the rectum is firmly attached to the sacrum. Usually tumor is large, but sometimes it is small and not noticeable. Notice it till it become infected or enlarged. That's to say complicated. This tumor has tendency for malignancy. Then sacrococcygeal teratoma. It is a pre-malignant condition, and MRI very useful in making the diagnosis. And treatments removal should be soon after birth, and delay may complicated by fatal ulceration, infection, rectal or urinary obstruction, or malignant change. Another congenital abnormality, post-anal dermoid cyst. The space between the sacrum and coccyx is filled with the dermoid cyst. The space between the sacrum and the coccyx is filled with the dermoid cyst. It regards simple form of teratoma. It's hidden in a hollow of the sacrum. Such cysts remain asymptomatic till adult life, where is prone to become infected and complicated, and treatment, surgical excision of the cyst. Pilonidal sinus. We start with important pathological disease related to the anorectal region is pilonidal sinus. Pilonidal sinus, it is acquired disease because it is occupational disease. Then who acquired disease? Because it is occupational disease. Because there is interdigital pilonidal sinus that occur in the hairdresser, interdigital pilonidal sinus. The age that occur between 20 to 29 years. This is maximum age for pilonidal sinus occurrence. Hair follicles have never been demonstrated in the wall of the pilonidal sinus. There is no hair follicles. Hair projecting from the sinus and dead hair disease most commonly affect and have high recurrence rate. It is usually affect males more common than female. إذن البايلونيدال sinus هو acquired disease. ليش؟ لأن ما عندنا hair follicle حتى نقول congenital abnormality. أكو dead hair. And the disease affect male and hairly male. That's to say male with hair. It's extend into subcutaneous planes as infected tract and stratified squamous epithelial lining of the pilonidal sinus, sometimes attain large size and depth, reaching the bone to the coccyx. The majority of pilonidal sinus occur in the skin of natal cleft. They may be solitary or appear as a row in the midline. Could be single orifice or multiple orifices. Mostly it is midline in the natal cleft, but maybe lateral orifice. Frequently, tufts of hair are found lying free within the sinus. Usually young adults are affected, male more than common, female, males affected more than females, and more often direct hair individual affected more than whitish people. The sinus are rarely seen in children and doesn't present until adolescence. They are an occupational disease of barber, hairdresser, in whom يعني عند الحلاقين. It is occupational disease. Whom the sinus occur between the fingers, between the digits. It's occasionally found in the axilla or umbilicus, on sole of the foot, as well as amputating his thumb. Then different sites for pilonidal sinus. And the clinical features of pilonidal sinus, it's chronic recurring sinus. Pilonidal sinus, it is a chronic or recurrent sinus in the midline about the level of the first segment of the coccyx. It discharge often blood stained and sometimes pus and contain full sebum and sometimes hair follicle, hair shaft become infected and give signs of symptoms of abscess collection. إذن البايلونيدال sinus or chronic recurring sinus at the level of coccyx, discharge blood, sometimes discharge pus, and when come infected, there is pilonidal abscess. About opening, sometimes single opening, and in chronic cases may have a row of opening. Even in cases we see opening on the either side of the midline. And it could be single orifice for pilonidal sinus, could be series, a lot of opening, could be midline, and sometime on either side of the midline. The pilonidal sinus is asymptomatic until it becomes infected when abscess formation, which either need drainage or spontaneous discharge. Treatment of the pilonidal sinus. طبعا بالنسبة للdiagnosis كلش واضح. By examination of the sinus during inspection, and after that palpation for any hardness and sometimes squeezing of the sinus would squeeze pus outside the sinus. Preventive treatments. In first time attack with mild symptoms can treat conservatively by cleaning. Then high conservative treatment in first time attack with mild symptoms can be treated conservatively, especially in female. Cleaning out the tracts, removing the hair from the area, and the frequent washing of the parts by detergents and water, and you have to avoid long sitting. Then the conservative treatment, you have to clean the area, remove the hair from the area, and the frequent washing by detergent and water, and to avoid long standing. Acute cases, if rest, bath, local antiseptic dressing, and proper antibiotic not being beneficial, the abscess should be drained. A drainage of abscess through small incision, and to remove all hair, and the tract can be destroyed by careful installation of pure phenol solution and the proper antibiotic. Operation done only when the inflammation controlled. You have to do complete operation and definitive operation when inflammation and abscess is drained. And the procedure by primary suturing after removing all tracts, after colored by methylene blue. إذن ممكن نسوي resection للبايلونيدال sinus وممكن primary suturing ولو إنه side effect is recurrence. It is usually complicated by recurrence by primary suturing. It is better to leave open and healed by granulation tissue. This is best method. Leave it open and healing by granulation tissue. And recurrence rate in primary suturing about 50% high. يعني كل اثنين one patient يرجع لهم recurrence rate. Cardiac 6 procedure involve closure is to one side of the midline. Closure to one side of the midline. And Bascom technique, Bascom procedure, all these operation pilonidal sinus involve incision مو بالmidline, لا, lateral to the midline, which allows the chronic abscess cavity to be scrubbed free of hair and granulation tissue. And causes of recurrent pilonidal sinus مهمة. Causes of recurrent pilonidal sinus, diverticulum of the main canal have been overlooked at the primary operation. هذا واحد من الكوزز. New hair enter the skin or the scar. ممكن يكون هذا second cause للrecurrence. When natal fold is deformed by the scarring, the least trauma causing tearing of the scar and become infected. The new subject is hemorrhoid. هسه خلصنا من البايلونيدال sinus. We start with hemorrhoid. مهمة. It means dilated veins in relation to the anus. It may be internal or external in relation to the anal orifice. إذن hemorrhoid هي dilated vein in relation to the mucosa and some mucosa of the anus and anal canal. Internal or external. Internal type covered by mucosa of the anus, while external covered by skin. Both type present, called internal-external hemorrhoid. And usual location for hemorrhoid at 3, 7, 11 o'clock. Lithotomy position. Why? Lithotomy position at 3, 7, and 11 o'clock? Because superior hemorrhoidal artery give right and left branches. Right branch divided anterior and posterior branches. And hemorrhoid may appear secondary to carcinoma of the colon because of the compression of superior rectal vein, or during pregnancy, during continuous straining in benign prostatic hyperplasia and urethral stricture, and during chronic constipation. إذن هاي etiological factors بالهيمورويد. إذن نسألك إنه شنو السبب صار عنده هذا هيمورويد؟ قد يكون هو first symptom and sign of CA colon, whether rectum or colon, or due to pregnancy or during continuous training in benign prostatic hyperplasia and urethral stricture, and during chronic constipation. Regarding the pathology of hemorrhoid, internal hemorrhoids or piles are abnormal anal Cushing's. Internal hemorrhoids or piles are abnormal. هي الهيمورويد اسمها pile. Are abnormal anal Cushing's, usually congested as a result of straining at stool and at defecation, and traumatized by the passage of hard stool. The anal Cushing's are particularly prominent in pregnancy due to venous congestion caused by large gravid uterus and laxity of progesterone. With the patient in the lithotomy position, the usual arrangement is 3 major piles, 3, 7, and 11 o'clock. These are the major piles, 3 o'clock, 7 o'clock, and 11 o'clock. In between, there is internal hemorrhoid or minor hemorrhoids. And important thing about the grading of hemorrhoid: first degree, second degree, third degree, fourth degree. First degree hemorrhoid confined to the anal canal and bleed but do not prolapse. Yeah, just bleeding, no prolapse. This is first degree. It is related to the and confined to the anal canal. While second degree hemorrhoids prolapse on defecation but produce spontaneously. This is second degree. Third degree hemorrhoid prolapsed outside the anal margin but manually replaced by the patient. إذن third degree إنه راح يصير عندنا bleeding، يصير عندنا prolapse but reduced by the hand of the patient himself or herself. And fourth degree hemorrhoid, it is permanently prolapsed. Regarding predisposing factor to hemorrhoids, most hemorrhoids are idiopathic, but they may be precipitated or aggravated by factors that produce congestion of the superior rectal veins. These include compression by any pelvic tumor, of which the commonest is the pregnant uterus, cardiac failure, excessive use of purgatives, chronic constipation, and rectal carcinoma. All these are predisposing factors. Pregnant uterus, cardiac failure, excessive use of purgatives, chronic constipation, and rectal carcinoma. Occasionally, anorectal very similar in appearance to esophageal varices. Occasionally, anorectal varices, that's to say, variceal veins يعني الهيمورويد similar to appearance of esophageal varices coexist with hemorrhoid in patient with portal hypertension. It is rare but present since the anorectal area is the site of portosystemic anastomosis between the superior and inferior rectal veins. Regarding clinical features of hemorrhoid, rectal bleeding is the most important. It is bright red and usually occur at defecation. Bright red bleeding, this is important symptom of hemorrhoid. In case of first degree piles, this is the only symptom. The second, a prolapse. More extensive bile prolapse. It may produce mucus discharge and pruritus anal. Prolapse is much later symptom, may result in soiling and mucus discharge. Note that the pain is not a feature of internal hemorrhoids, except when these undergo thrombosis. بصورة عامة بالهemorrhoid, it is painless disease. It is painful only if it is complicated. Anemia usually occurs due to continuous profuse bleeding. When patient complain of attack of bile, it often means that some acute painful condition has developed at the anal margin. The most common and dramatic is strangulation of prolapsed piles. Strangulation is one of the complications and important complication of hemorrhoid lead to thrombosis. Apart from acute pain may be due to the following: either fissure in anal or perianal hematoma or perianal or ischiorectal abscess, tumor of the anal margin, or proctalgia fugax. Proctalgia fugax begin as episodic pain relieved by digital dilatation of the anal sphincter. Every patient present with the story suggestive of internal hemorrhoid is subjected to the following procedure: examination of the abdomen to exclude palpable lesion of the colon, tumor, carcinoma, or aggravating factor for hemorrhoids. For example, large liver, pelvic masses, and include the pregnant uterus. And rectal examination by PR examination, internal hemorrhoids are not palpable, but predisposing piles are prolapsing piles immediately obvious by inspection. It is clear by inspection. A prolapsing pile doesn't exclude a lesion higher in the bowel. Presence of prolapsing piles يعني احنا hemorrhoid ما تعني فقط hemorrhoid، قد تعني انه CA rectum. Proctoscopy, which will visualize the internal hemorrhoid. Proctoscopy also visualize the anal canal at our lower rectum. Also, we can see internal hemorrhoid and origin of internal external hemorrhoids. Sigmoidoscopy is performed routinely, again, to eliminate lesion higher in the rectum, like proctitis, polyps, inflammatory bowel disease, or carcinoma. and barium enema is carried out in any cases where symptoms such as alteration in the bowel habits, and sometimes it is a sinister manifestation of internal hemorrhoid. Sometimes internal hemorrhoid, it is the features of underlying carcinoma of the colon, and colonoscopy may be indicated to visualize and biopsy any lesion thus revealed. يعني old age, more than 50 years, bleeding per rectum, PR examination, we reach for a mass or not reach or palpate mass, you have to do proctoscopy, after that sigmoidoscopy, and may end with colonoscopy, because hemorrhoid may be a feature and manifestation of carcinoma. Okay, we start. Next lecture, we start with complications of hemorrhoid. Thank you very much.